Because the other one's, you know.
I'm sorry, we were done with our conference at 12, but I'll give them a call and give them an update. I just wrote it down, yeah.
Okay, perfect. As long as the next person is, you're working on it.
It's gonna be next week.
I have a solution.
If you have, it's not really
Yeah.
Oh yeah, that's terrible. The foamy stuff, it like stays on your
Are
hand.
you guys okay? Because I can use this.
I thought you were just nervous.
Yeah.
Someone who's probably statutory authority. Oh yeah, the prison.
Yes.
Well, I don't know. I just assumed.
God knows.
Right, we haven't heard, so I can just
Yeah.
ask.
Yeah.
You're not.
But I'll let you know. But I just assumed that.
Yeah.
But yeah. There are more than 10 people. So he's talking to,
And they'll send you stay away. And there's a town called Pet North. And that means I. Oh, the doctor has arrived.
Good morning, everyone. How is everyone? Good. Well, good morning to everyone tuning in right now as well. My name is Dr. Nirav Shah, and I am the director of the State of Maine Center for Disease Control and Prevention. I'd like to provide an update on where things stand with respect to coronavirus or COVID-19 across the state. Before I begin, I'd like to acknowledge the fact that there are dozens, hundreds of people across the state working intensely on this situation, many of whom are at our agency. But there are a lot of folks out there who are also helping us share information and get the word out about where things stand. And this morning, I'd like to begin by thanking one of those individuals, someone that each of you knows because you see her at each of these briefings. And that's the person standing to my left, Dr. Regan Thibodeau. Dr. Thibodeau, thank you for helping us get vital information about the coronavirus situation to as many Maine people as possible. To start off, I'd like to just discuss the cases. Maine CDC is currently reporting 52 cases of COVID-19 across the state. This reflects 10 additional cases since yesterday. It also reflects an additional county with 1 case in Hancock County. I can also report that we have detected 2 additional cases in individuals who reside at the Oceanview facility in Cumberland County. At present, 4 individuals are hospitalized. 1 individual remains recovered. And all told, there are 42 confirmed cases and 10 cases that remain presumptively positive. In total in Maine, there have been 2,004 negative test results, and laboratories across the state continue to process those results on a day-to-day basis. I'm also pleased to report that, as many of you may be aware, there have been shortages of hand sanitizer at locations across the state. Recognizing the importance that good hand washing and hygiene are to this situation, and recognizing those shortages at certain outlets, the administration today has issued a standing order for any compounding pharmacy to allow and enable those pharmacies to make their own hand sanitizer and sell it at their establishments. This is not a requirement, it is an option for pharmacists to make and compound their own hand sanitizer to allow it to be sold on their shelves. We hope that this will alleviate any shortages of hand sanitizer that may be existing in the state right now. I'd also like to discuss a bit of where our focus at the Maine CDC is. Based on emerging data that have come out over the past several weeks, we are sharpening our focus to a few groups of individuals right now. One is those who are hospitalized. The second are healthcare workers. Another group are our very important and vital first responders out in the field. The fourth group are individuals who live in congregant settings, such as people experiencing homelessness. And then the fifth are individuals who are in different special populations, such as women who may be pregnant. By sharpening our focus, what I'm referring to is aligning our guidance with that of the US CDC for situations of this sort, and ensuring that folks who are in those categories can get tested quickly and that we can get results back to healthcare providers as quickly as possible. The last thing I'd like to touch on again is the importance of practicing social distancing. We've talked in these meetings about how social distancing is one of the surest and most efficacious ways that we as a group, as a state, as a large community, can flatten that curve. Although social distancing is the recommendation of the Maine CDC, we have to be cautious in order to prevent an epidemic of COVID-19 from becoming an epidemic of loneliness. So while I recommend that everyone socially distance, I also recommend that everyone socially connect in different ways. Whether that be through FaceTime and other conferencing apps, whether that be calling an old friend you haven't talked to in a long time, or sitting on your porch and waving at your neighbors. Everyone should still remain socially connected, even as we introduce a little bit of physical space. That does not mean we have to introduce absolute space. The other thing I'd like to note is that just yesterday, the U.S. Center for Disease Control published an analysis of individuals who are hospitalized with COVID-19. And what was concerning about that analysis to me was that roughly 40% of the individuals in their data set who were hospitalized were between the ages of approximately 20 and 40. This again underscores two things. Young folks are not immune or invincible with respect to COVID-19. It also reemphasizes the fact that all of us, young people included, need to take the recommendations and engage in social distancing. In times like this, I go to one of the luminaries in the public health world, the band Coldplay, and ask myself, and we should be all asking ourselves this, are we part of the cure, or are we going to be part of the disease? And in this situation, I ask everyone to be part of the cure by practicing social distancing. So with that, happy to take any questions.
Question about Old Orchard High School. Has CDC talked with all of the parents, the children who might have been in close contact with a staff member there who apparently is one of those positives?
The question is, how does CDC work in situations where an individual affiliated with a school may be confirmed as having COVID-19? I can't comment on any one specific school for privacy reasons, but what I can tell you is that in situations where an individual affiliated with a school community has been identified, what Maine CDC does in each and every one of those situations is first notify the school officials, the superintendent first and foremost, and then the school nurse. We do that because in these situations, the surest and the fastest way to get the word out to that school's community is through the institution itself. They've got the contact information, they've got the addresses. We furnish the information that they can use to get out ASAP. We then, in these situations, start working with the family, as well as any individual student who may or may not have been there, to determine what extent they had close contacts. There's a difference in investigations of this sort between casual or incidental contacts and close contacts. Maine CDC's focus is to identify close contacts so that we can be in touch with them directly. The school, in these situations, identifies all potential contacts.
Dr. Shaw?
Yes, Steve.
Could you tell me has Maine CDC done a census of how many ICU beds and ventilators it has? Can you tell me what the numbers are?
Sure. So Steve's question is, have we done a census on available healthcare resources? That census is underway. We launched it on, I believe we launched it on Friday, Steve. I can't recall if it was Friday or Thursday of last week. And hospitals are asked twice per day to go into a resource that they are familiar with that logs the number of available and occupied beds, available and occupied ICU beds, and available and utilized ventilators. I don't have the latest numbers with me at this very moment. Not all hospitals have reported in quite yet. So where we are in the process as of last night was touching base with those hospitals individually to make sure that they were doing so. As soon as we have those numbers in a representative format, I will share them with you.
That's great. May I follow?
Yes, sir.
And I'm just, this is a question from my colleagues. I'm going to read it if you don't mind.
Mhm.
Modeling of hospital bed capacity by the Harvard Global Institute shows that Maine will only have enough beds, both regular and ICU, under a best case scenario where only 20% of the population is infected over a 12 to 18-month period. What are we doing to prepare in case things are worse than that?
Great. So Steve's question is, if the situation becomes significantly worse, how are we thinking about hospital bed availability, as well, I would add, with availability of other resources? So here's where we are in our thinking. The first, of course, nationwide, hospital beds, particularly hospital beds for critically ill individuals, are a constrained resource. And we should all recognize that. What we have been doing is a few things. The first is really studying who should be in the hospital versus who can be safely isolated and cared for at home. As we learn more, and by we I mean the international health community, learns more about the course of illness with coronavirus, we have a finer sense of who can be safely cared for at home versus who really, truly needs to be in the hospital. So as that data come in, those models, such as the one you referred to, are continually refined. And what we have been learning is that an increasing number of individuals can be safely cared for at home. That's a good sign. But we're not waiting, we're not just going to rest on some good numbers. We're also working with our colleagues at the Maine Emergency Management Association and their contacts with FEMA to start thinking about alternative care sites, as they are called. These are situations where individuals may be cared for who need hospitalization, but maybe not in a hospital per se. And so there's plans there's thinking going on about converting existing facilities that may have been decommissioned in recent years to accommodate situations like that. The third thing that we're doing specifically in the resource piece is thinking more about ventilators. And what I'd like to say with respect to ventilators is that as we've talked about with, say, the laboratory, just having a ventilator is only the first necessary step. You have to have someone who can insert the tube, a process called intubation, which is technical. You also have someone who can program the ventilator. What we've been thinking about are a few things. First is making sure that non-hospital workers, that is to say, field workers like paramedics, their skills in intubation are where they need to be. We're also thinking about utilizing telemedicine, among many options, so that if high numbers of people need to be on ventilators, experts from other parts of the country can adjust and fine-tune those ventilator settings on an occasional basis, even if they may not necessarily be here. So there's a lot of thinking going around on that issue. Let's hope we don't get there.
Do you have a sense of what is the training requirements for the people you just described that you want to have trained up on this? Do you
Good.
have a sense of whether or not that's already happened?
Yep. So a lot of first responders, namely paramedics, can already intubate individuals in the field. But again, we want to make sure that they are ready to heed that call if we need them in hospital settings. So, other questions? Yes, sir.
The IW is still open right now. Maine Mall is also, they've reduced their hours, but they're still open as well. What would you say about that? I know the governor didn't ban those things or close the things, but you talk about that.
Yeah, I would, candidly, and the question is how should we think about large businesses right now? Candidly, I would reflect on what the governor said yesterday. Many of those businesses, namely BIW, which you referenced, occupy a special place in our national security architecture. The governor spoke about this yesterday evening yesterday again on a radio program. I would really refer you to her comments on that. Yep.
Dr. Todd, can you say any more? Is there evidence of community spread pertaining to any of these new cases?
Based on where we are, the question is, have we detected additional evidence of community transmission? Again, community transmission refers to the finding of an individual who has a disease that is not directly connected to travel or directly connected to another individual who has returned from travel. In that sense, community transmission is like the flu. You get it potentially just from your own community. At this time, Maine CDC has detected community transmission in Cumberland County. We remain focused on looking for evidence of community transmission in other parts of the state. As we find new cases in other counties, one of the first questions we ask those individuals is, where have you been? Have you traveled? Is anyone in your family been traveling? Is anyone that you come into close contact with been traveling? If and when we detect that the answers to those questions is no, that gives us evidence in favor of community transmission. At this time in Maine, that has been Cumberland County, but we are closely attuned to that possibility, and we should be very clear. Community transmission has occurred in many parts of the United States, beginning in the Pacific Northwest, but now in the Northeast and in New England, and we do anticipate community transmission in other counties in Maine. What we do not know when we talk about community transmission is the magnitude of that. Even if community transmission may still be occurring in a county, the magnitude of illness is something that we don't have a handle on. It still may be the case that a high number of individuals in those counties have mild illness, even if they acquired it in their community. So I just want to be very clear. The numbers are one thing, but the magnitude of illness also has to be kept in mind.
Dr.
I'm gonna, sorry, yeah, wait, yeah.
How concerning are the additional cases at Oceanview and Falmouth, and what additional measures, if any, have you recommended for that state?
They are concerning. Based on what we've seen in other communities of this sort across the country, they are concerning. This facility in particular has different facets to it. Some individuals live in independent living houses, cottages, as they're known. Others are in assisted living. Others are in memory care. As soon as we detected the first cases on Sunday evening, if I recall, Sunday, the very next day, we had Maine CDC field epidemiologists who were on site at the facility. We provided recommendation, I can't recall which day, we immediately provided recommendation to the facility on doing a few things. The first was notifying everybody, staff, residents, and family members of residents, so they could take whatever appropriate steps they needed. The second thing we did was to institute, or rather recommend, that the facility restrict visitation. We're taking another look at the situation right now. My team spoke with the Oceanview facility not too long ago. I should emphasize that we just received word of these cases not even 2 hours ago. So we're reporting them in very much real time out of an abundance of transparency. But based on what we've seen in other parts of the country, we are concerned. However, this is not the same sort of long-term care facility that we saw be an epicenter for cases in, say, Seattle, King County. But given the vulnerability of the members, the residents here, we're taking this very seriously.
And do you know where the cases are in Oceanview in terms of cottage?
I do, but I'm not able to disclose that for privacy reasons. Each of those 3 units has a small number of individuals. We are aware, and as you can imagine, we are paying special attention to those areas, but residents at the Oceanview facility socialize. And so irrespective of where they may live within the facility, we're treating the entire facility as one. Also part of the reason we're not disclosing where specifically within the facility they are.
Two questions.
Yes, sir.
Relating to social distance and community transfer. One, the governor yesterday restricted public gatherings to no more than 10 people. Is there a particular basis for that number, or is it just an arbitrary to make it smaller? And the second question is, some of the coastal communities are having people come in, people out-of-state folks who have summer homes. Some of them are opening those homes, coming in to get away from the cities. Some other people looking to rent to do the same. And I've heard comments from local people who say, gee, are they presenting a bigger risk to us of bringing in the disease or using up resources, whatever it might be? Can you comment on both of them?
Sure. The first question is, what can we say about the governor's recommendation, now executive order, regarding gatherings of individuals of 10 or more? And what we can say about that is that social distancing is most effective before there is widespread community transmission. After widespread community transmission has been detected in places like New York City, Seattle, there is still a role for social distancing. But the impact is not as great, and candidly, in situations like that, it may be even too late. Why I say that is because the time between when someone is exposed and when they get infected is anywhere from 4 to 6 days. So when you're looking at coronavirus, it's like watching a live news broadcast that was actually recorded 4 or 6 days ago. We are now seeing the effects of exposure from several days ago. And as a result of that vital incubation period, we have to take steps now before we see that movie play out even greater. And that's why the more aggressive that we can be now, the more that curve can be flattened. 10, as the number you raised, you know, there's been a lot of experience around the world over the past 100 years with social distancing, really starting, among other places, during the 1918 pandemic. And what we know from those data, among other things, is that the more aggressive social distancing was, the better off cities fared. So that's kind of where we are with that. Now, with respect to outsiders coming in, here's what I'll say. I've lived in Maine now for 9 months, and never have I lived in another part of the world that is as welcoming to those who are from another part of the country as I've been in Maine, and I hope that it stays that way. Yeah, Steve.
You mentioned the age groups that seem to be that are hospitalized, which I think is reflective of what we're seeing nationally.
Mm-hmm.
What's your read on that? I mean, I think when this originally happened, we were talking about people hospitalized who were a lot older, and yet we're seeing people in their 40s and 50s who are hospitalized. What does that tell us?
You know, I think, so Steve's question is, how should we think about some new data from the US CDC regarding who has been hospitalized for coronavirus? And again, these are publicly available data that were published by the US CDC yesterday. Personally, I took pause when I read them. There had been, from early data in China, as well as Italy and South Korea, the notion that the most disproportionately affected were the elderly. And that still remains the case, to be sure. But those data that we've talked about at these meetings earlier were principally about fatality, mortality issues. We're now starting to get a better glimpse, not just on who passes, but on who suffers hospitalization, what we call morbidity, in addition to mortality. And what the data tell me are two things. The first is we need to make sure that the concept and the message, the importance of social distancing makes it out there. Folks who are older don't tend to be the ones congregating in groups, concerts, things of that nature. It tends to be folks that are in this middle category, this younger category. So what it tells me, and one of the reasons I talked about this today, was to really re-emphasize the importance of social distancing. And Steve, what I would say, and what I would say to everyone watching, if you're in this category of folks who are 20 to 40, there are two reasons why I'd like you to do your civic duty and practice social distancing. One is so you don't end up in this 40% group that has been hospitalized. But the other is that by social distancing, you reduce your likelihood of picking up the virus. Even if you yourself don't get sick from the virus, you might inadvertently transfer it to your grandparents. So by social distancing, especially with this younger crowd, we can keep folks from getting sick on their own, but we can also prevent this downstream transmission to older, more vulnerable individuals. Actually, I'm going to turn on this side of the room and I'll come back to you. Yep.
Hi. So one thing I was wondering is the role of testing.
Mm-hmm.
And so let's just looking ahead a little bit. Let's just say that we get a greatly expanded number of tests, whatever that might be, 4 weeks from now, whatever that may be. And we still don't have widespread community transmission. Maybe we've been somewhat successful in flattening the curve. Does the role of testing change at that point, or like how does that dynamic work?
Great. So the question is, how should we think about testing going forward? And in a world where, so there are some things that we're learning about the disease. Although hospitalization rates for younger folks are higher than we thought, perhaps, it still remains the case that approximately 80% of individuals with coronavirus, COVID-19, have mild symptoms and can stay home. They recover on their own. They don't need intense hospitalization. The other thing that we are learning is that as community transmission occurs in more and more places, it is likely to happen here. In that setting, in that world, epidemiologists at the US CDC are thinking very critically about what testing means there. generally speaking, in healthcare, the reason you test, there are a lot of reasons we test people. One is so that we can tell our patients what's going on. But from a medical management perspective, one of the reasons for testing is because it might change the course of what a doctor recommends. You want to test in a situation where that test changes your decision making. And in a world where most people fare okay, and we know that it is circulating in the community, epidemiologists at the CDC, the US CDC, are thinking about whether the testing protocol should be angled to test for some of the focus groups that I mentioned earlier. And there's already actually CDC guidance, US CDC guidance on this. We at the Maine CDC are evaluating it as well. Because again, we really want to focus testing so that doctors can get the results back quickly and make clinical decisions on it. So I think that's where I'll leave it. Randy?
Yes, question regarding the National Guard, and I'm just wondering if you guys have, how much have you thought this through, and what role potentially could the National Guard play in the state CDC's response, and at what point would they be needed or activated in this?
Yep. So Randy's question is, what is the role of the National Guard in situations like this? And it's something that we've thought about. It's something we've talked about. Had collectively conversations with General Farnham, as well as, of course, Director Rogers at MEMA about this. Right now, the National Guard is apprised of the situation. Your question, though, is in what way might the National Guard be utilized? And what I can tell you, Randy, is that in other states, the ways that they've been deployed, most notably recently in New York, in Westchester County. And there, the National Guard was deployed to do things like triage, by which I mean answer phones. Many of the National Guard members in Maine are medics of different sorts. So we have thought about the ways in which they could support the activities of our public health nurses, which we discussed yesterday. But right now where we are is we are looking on our internal force of public health nurses and epidemiologists, recognizing that every single National Guard member has a job. And so there's a trade-off between deploying them and taking them away. So what I would say is that we have thought about it. They brief with us. They are very well aware of the situation. We have scenarios in mind, but as of this time, our stance is preparedness and not deployment. Going to go back over here and then, yep, yes.
Hi, could you give us a county-by-county breakdown of the numbers?
I will be able to. There's new case, based on the speed at which we just got these cases, I don't have the county-by-county breakdown. Okay. Let me just, it might be on my phone, but we'll get that to you ASAP, and certainly it'll be on our website.
Okay, thank you.
Yep.
I noticed the Mills just put out a news release about asking the federal government about getting more pandemic supplies, and also worries about testing capacity, in the near future, that we're starting to run out of tests. And so I wonder if you could address both those topics. Is there anything that can be done other than sending a letter, and what about the testing supply?
Great. So Governor Mills did send a letter to the Vice President and I believe Secretary Azar as recipients, outlining two challenges that we are having in Maine that other states have had as well, challenges that are well known to everyone watching. The first is around the rollout of personal protective equipment, and the second is around testing supplies. Now, the letter is just one piece of an effort. The letter is not the only thing. Each of us, my counterparts in the administration and commissioners, are on multiple calls per day. I personally have indicated to the US CDC, as well as to the Assistant Secretary for Preparedness and Response's office on phone calls, that the rollout of personal protective equipment is not as fast as it needs to be. Now, with respect, and so the letter reflects that it is not the only thing we've done, but it amplifies the message, of course, coming directly from the governor. But it is part of a broader effort and something that we've discussed here, which is that the rollout of this protective equipment that our first responders and healthcare employees use, two groups that are of high focus for us. Even though we have received a shipment, we need more. Right now, the U.S. Strategic National Stockpile has the keys. And what we're asking them to do is to open up the doors even more and speed out the rollout. The same thing applies with testing supplies. Testing, in a sense, it's like baking, right? There are a lot of things that go into baking. You've got the oven, which in our case is the equipment that runs the tests. But there are a lot of ingredients that go into the bowl before you can put something in the oven. Lots and lots of ingredients. The things that we've talked about in the test kits that were of high focus a few weeks ago are the DNA fingerprints, or in this case, the RNA fingerprints, that we use to compare a sample from a patient to the reference. That's one piece of the testing. That's just one ingredient. What we and other states are concerned about is the supply of other ingredients, most notably what are called reagents. This, in my mind, is kind of like the baking powder. It's the chemical that makes the reaction go. And right now, there nationwide are concerns about the supply of those reagents. That's one reason we are discussing this. It's one reason my colleagues and I, on every single call with the US CDC, are asking them to speed up the delivery of reagents. I'm going to, go over there and then I'll go back to you guys.
When
Yep.
you said the average number of people hospitalized are the ages 20 to 40, did you say that was in the state or is that global?
Global, nationwide. I believe that is from US data. We will get you the actual publication from the US CDC. It's also available on their website. It's not proprietary. It was published by the US CDC in their official scientific journal. And so we will get that to you, and that way you'll have the exact numbers, not the approximations. We will also put it on our website so that every single person who's watching right now in Maine can take a look at those data. This is real time. These are data that were released about 16 hours ago. We want everyone to know about what we are looking at as we are making the decisions. Part of the reason that I'm doing these briefings and want to continue to is that things in public health emergency response change hour by hour. Now, not because we just decided to change procedures one day, but because new data comes in. That's why when we talk about doing something data-driven, this is what I'm talking. This is really the essence of doing data-driven response. New data come in, they're well validated, published by the indisputable experts at the US CDC. We then interpret those data to determine what the impact and the operational significance of them are, and then we make changes in real time. I am really proud of how nimble my team has been. I referenced another similar change a couple of days ago when we changed the look-back period when we do investigations from 14 days to 16 days. That's because of new data that came out on Saturday night, and by Sunday afternoon when we were looking at a residential facility in Falmouth, we had already changed our protocols. We will make all of those papers available. If anyone wants to see the published articles we're looking at, we will get them to you.
And are doctors and nurses working overtime hours through this?
I believe so, just based on anecdotal reports I've received. Certainly my team at the CDC has been putting in yeoman's hours, coming in nights, days, weekends, you name it. With respect to doctors and nurses, in order to be 100% accurate, it'd probably be safer to just ask the facilities themselves. By anecdotal report and some of the doctors I've talked to, I know that they are working as hard as my team, at our team in state government at the Maine CDC is working, but I want to make sure I give it to you straight. Going to go back to this side of the room. Steve, Randy, I'll let you guys work out who wants to go first.
So yesterday, as you are aware, I'm sure, that the president announced he was authorizing or invoking this Wartime Powers Act called the Defense Production Act. He wasn't specific about how that would be utilized. I'm wondering if you, in your conversations with your federal counterparts, have any more clues about how that will help with the PPE situation, and also how quickly can they ramp up something
Good. So Steve's question is in connection with statements made by President Trump about utilizing certain powers that the president has to ramp up production of necessary vital supplies. Steve, what I can tell you is that I'm not sure what is in the offing for them, nor do I have a sense of what their ramp-up period would be. What I can tell you, what we need are personal protective equipment generally, and specifically these N95 masks that we've talked about. If I were to recommend one thing, that's where I'd start. The second thing I would recommend would be ramping up production however they can of some of these other ingredients that are used in testing, these enzymes, these reagents, these transport media. That would be the second thing. There are certainly other things that we need, but right now, that's what I am the most concerned about. Randy.
Back to the issue of homelessness, there are some other states who are, taking over gymnasiums to set up cots to get that social distancing between folks. And we found some CDC guidance that says, head to toe is good, but you need to have that 6 feet in between. Is this still like an exclusively local decision, or is the CDC going to step in here and issue an edict on this?
By the CDC, and I'll repeat the question. Yeah, I'll repeat your question, but by CDC there, you're referring to Maine CDC, or is it US CDC?
The US CDC.
Got it. Okay, so Randy's question is with respect to people who are experiencing homelessness, and what might the future be for them as it relates to COVID-19. And let me start by noting that very earlier on, when we started thinking about individuals who live in congregant settings, people who were experiencing homelessness were at the top of our concern list, as well as individuals in other institutional settings. As everyone may be aware, the city of Portland has been really active in thinking about this. And Randy, after our discussion yesterday, I went home and checked on the head-to-toe thing, probably read the same guidance that you read as well. It's a first and good step, but not necessarily all that needs to happen. US CDC has been thinking about this more intently, as have the teams at the Maine CDC. I'm not aware of any sort of edict or directive coming out in the near future. But what I can tell you is that we've got a team at Maine CDC that's working with nonprofit organizations, healthcare providers, and city officials, both in Bangor as well as in Portland, to think about these issues. It's a pretty diverse team in both cases. It's not just Maine CDC, candidly, it's the entire Department of Health and Human Services. And we're looking at a number of things. The first is arranging for safe testing. The second is when an individual tests positive, how can those individuals be safely housed? Maybe that's in a commercial setting, maybe it's in a cohort situation at a large space. And then the third, of course, is ensuring good follow-up. At baseline, what we know is that people who are experiencing homelessness, their health status coming into any illness is lower than individuals who have stable housing. So for the 80% numbers that we've talked about who do well, what we don't quite yet know is how do individuals who are experiencing homelessness fare? And so how can we make sure we provide them not just with safe, stable housing for the course of their illness, but continued health care? It's very much top of mind, as are others in the institutional settings, such as corrections, et cetera. And there's much more to come. Going to go back to this side of the room. Yep.
Is there anything you can draw from the day-to-day case numbers so far in terms of are we having in Maine any success or not success in flattening the curve? And then a follow-up on the testing too, is there a number of how much additional testing capacity we have that we haven't tested yet?
Great. So the first question is, what can we say about the numbers that we've got so far? And in particular, are any of the social distancing measures that we have recommended, asking people to be part of the cure, not the disease, are those having an impact yet? Candidly, it really is too early to tell. One of the reasons it's too early to tell is that we're looking at a counterfactual scenario that doesn't exist right now. It's not as if we can compare ourselves to a state that didn't employ these measures. So everyone right now is kind of in the same boat. So that's just the completely candid scientific answer. It's too early to tell, and let's just continue to hope for the best. But that does not suggest that these measures are something that we don't know whether they work, right? I just want to be really clear. We've talked earlier, and I can provide anyone the paper that really did a deep dive into the experience during the 1918 pandemic, comparing two cities, one that did employ aggressive social distancing and another city that did not. And it won't surprise anyone, given that we've endorsed these recommendations, that even going back over 100 years ago, public health officials knew that distancing made an impact. The data from those experiences in 1918 have borne that out. With 50 cases, it's very difficult to make any counterfactual or good comparison, but based on over 100 years of public health history and knowledge, this is a strategy that we know works. Joe, your second question was around testing.
Yeah, just like, we know that there's some issues with the supply chain, and so I'm wondering, as it stands right now, how much further additional testing capacity we have with 5,000, 10,000?
One of the reasons that we're focusing on the highest, most at-risk groups is to make sure that those groups can continue to receive tests. The numbers of how many tests we have available really do determine or do depend on what we see with the outbreak going forward. And we're hoping that if we can focus doctors' attention and testing attention on the highest at-risk groups, that we can preserve that testing for a long enough period so that we can continue to get reagents. I think I've got one or two last questions. Going to bounce back over here, and then you'll get the last question. Yes, sir.
Do you know how many, systemic 3 cases at Oceanside, and do you know how they got it? Was it a visitor who brought it in, and have they been told to practice social distancing?
There are 4 total cases at the Oceanview facility. 2 of those cases are in close household contacts. We are continuing the investigation into where they might have acquired the illness, but as of right now, it is classified as community transmission. We have strongly recommended that they do so. My understanding from the field report that we received is that they are, but we are going to re-emphasize that recommendation as well.
And one last question.
Yep.
Are any of these patients right now struggling with coronavirus?
We have 4 patients who are hospitalized. I can't comment specifically on the Oceanview individuals for various privacy reasons. There are, out of our 52 cases, 4 who are hospitalized. And once again, our top priority at Maine CDC remains to be working with the healthcare providers who are working with those patients in order to have them have the speediest recovery possible. Last question, sir.
You mentioned early on, Doctor, that you're focusing some priority populations, one of which I believe was maybe 2, first responders and healthcare workers. Given that we've had at one hospital an ICU nurse tested positive, how concerned are you about the need to protect the healthcare workers?
So the question is, speaking about healthcare workers, and I want to speak to healthcare workers right now, because we recognize that you are the backbone of the system right now. Without healthcare workers, without maintaining the health of our healthcare workforce, many of the things that we've talked about during these briefings don't happen. Whether that's quick screening, ventilation, whatever the case may be, all of those recommendations from public health are effectuated by healthcare workers. And so they are one of our focus areas right now. When we talk about protective equipment, PPE, the place that we deploy those PPE, first and foremost, are to healthcare workers. We want them to stay as safe as possible. Based on data that have come from other countries, we fully recognize the risk that healthcare workers face. We want them to have the PPE that they need in order to take care of patients as well as to continue testing patients. If we are not careful in the way we approach this, one of the concerns that we've talked about that I've had may materialize, which is that coronavirus may go from being a travel-associated phenomenon to a community-associated disease and finally, to a healthcare associated disease. So for that reason, as you noted, two of our highest priority groups right now are healthcare workers, those who work in hospitals and our vital first responders on the ground. Thank you very much, everyone. I look forward to chatting again soon.
We'll be in touch with plans for tomorrow. We may mix things up. Your producers and editors may also be hearing about ways that we can incorporate social distancing